Hi, my name is Fred Kowal, President of United University Professions. And once again, I'm reaching out to you with an update about our ongoing negotiations with the state of New York about the implementation of the vaccine mandate. As always, I want to begin by thanking all of you for your tireless efforts each day to make our communities, our campuses, hospitals, and state safer for everyone. The past 18 months have been unprecedented in terms of the monumental challenges we have faced. Yet you continue to rise to meet them with grace and unwavering dedication. For that, I am extremely grateful. As I mentioned earlier this week, UUP unequivocally supports every New Yorker getting vaccinated against COVID-19. There is simply no better way to help do our part to end the pandemic and keep ourselves and our communities safe. However, while we believe in the vaccine and urge every UUP member to get vaccinated, we also made it clear to the state of New York that we could not support any mandate that denies our members due process, a fundamental right guaranteed to union workers. We immediately reached out to the state to advocate on behalf of you, our members. After nonstop negotiations throughout the week, UUP has secured crucial protections for our members ahead of the state's September 27th deadline for vaccination. First, when the vaccination mandate goes into effect, unvaccinated workers at our SUNY hospitals will not be terminated. Instead, they will be placed on disciplinary suspension and receive all the due process protections provided by the UUP contract. During this unpaid suspension, those members may elect to charge available leave credits. In addition, health benefit coverage will continue. Second, unvaccinated members will be served with disciplinary charges and have the opportunity to grieve those charges in an impartial disciplinary hearing process before any final disciplinary action is taken. This is an important win for all of us at UUP. Our negotiations cemented workers' rights to due process and stopped a substantial overreach by the state. While I firmly believe that every New Yorker should get a COVID-19 vaccination, it is also fundamentally important that we never back down in our fight to protect the rights of our members. I am extremely proud to deliver the news of this victory to all of you today. In addition to the protections secured today, we continue to press upon Governor Kathy Hochul's office and SUNY that our public teaching hospitals and healthcare professionals have faced years of underfunding and understaffing, which was exacerbated by the pandemic and will be made worse by the mandate. We will continue to provide updates on our negotiations as they come. For now, thank you, all of you. Thank you again for the incredible work you do every day. Please, if you have not yet gotten vaccinated against COVID-19 and are able to, get the shot as soon as possible. By doing so, you will help keep our communities, our workplaces, and our fellow members safe. Thank you very much, and take care. The goal today is to provide information directly to UUP members who have concerns about the COVID-19 vaccines. I am Dr. Fred Kowal, President of UUP. My goal and the goal of the entire leadership of UUP has been, again, from the start of this crisis, to provide as much information as possible to all of our members throughout this time period. This commitment has propelled us to put together this panel on very short notice, and I really want to acknowledge the commitment of UUP members who are joining us today as panelists. And also the one on Friday. And the whole intention for all of us is to learn as much as we can about the vaccines and the COVID crisis we are facing. We want to answer as many questions as possible. That's the fundamental goal that we have. Now, this conversation that we are about to commence is serious and very necessary. Strongly held positions, strong emotions, and deep-seated fears are all present at this time around this issue of vaccinations and the recently announced vaccine mandates. Though that be the case, the rule for this discussion is one that I will hold all of us to. We, as a union, as members of the SUNY community, must be committed to civil and respectful discourse. As is always the case in meetings that I chair, I will insist on such behavior during this discussion. We have much to discuss, and hopefully we will learn much through the course of this conversation. That is the goal of today's panel. With that, I would like to introduce the members of the esteemed panel of experts, colleagues that have joined us today. First, joining us from Downstate Health Sciences University is Dr. Camille Clare. Dr. Clare is the chair of the Department of Obstetrics and Gynecology, as well as a professor at the College of Medicine and the School of Public Health. Dr. Clare is a graduate of the Albert Einstein College of Medicine of Yeshiva University and completed her residency at the State University of New York at Buffalo. We are also joined from Downstate by Dr. Michael Augenbraum. Dr. Augenbraum is the director of the Infectious Disease Division at Downstate. Dr. Augenbraum received his medical degree from the University of Rochester School of Medicine and Dentistry and has been in practice for more than 20 years. Joining us from Stony Brook Health Sciences Center is Dr. Brianne Neveda Modrov. Dr. Neveda Modrov is an allergist and immunologist in the Division of Rheumatology, Allergy, and Immunology within the Department of Medicine at SUNY Stony Brook University's School of Medicine. Dr. Neveda Modrov completed her fellowship training in pediatric and adult allergy and immunology at North Shore and Long Island Jewish, Northwell Health, and earned her MD from Albany Medical College. And joining us from Upstate Medical University are Dr. Katie Anderson and Dr. Jeanette Zechler. Dr. Anderson is the director of the Center for Overseas Research in the Institute for Global Health and Translational Sciences at Upstate Medical University. Dr. Anderson is an internist and infectious disease epidemiologist. She is an assistant professor of medicine and biology and immunology. She has worked in the field studying dengue epidemiology for over a decade. She first began studying dengue virology at Colorado State University and then received her MSPH at Emory University, where she worked with the CDC studying dengue in Vietnam. Dr. Zechler is the Director of Preventive Services at Upstate Medical's Occupational Health Clinical Center. Dr. Zechler develops and implements collaborative public health initiatives to expand the Occupational Health Clinical Center's preventive agendas through outreach, education, and research. Dr. Zechler completed her MPH at SUNY Upstate Medical University and her PhD in social science at Syracuse University. That is the panel, and we are honored to be joined by all of you to be a part of this program. And certainly, we welcome all of you who have taken the time to be a part of this in the audience. Although it's not really a role that you have, you're not an audience, you are going to have the opportunity to ask questions. The intention here is to provide information through questions that have been previously submitted, and then, as time allows, questions from the audience that is joining us today. As I said, we have received many questions submitted through the registration portal. I'm going to begin with those, but if you did not have a chance to submit a question, please feel free to raise your hand. We will have medical experts responding to questions in the chat as well, so you can post a question there. And then once we get through the previously submitted questions, we will go to those who have raised a hand with an additional question. But let me say this, the questions we've received cover a wide gamut of concerns that have been raised about the vaccines and the vaccination program. And so with that, let us begin. I will turn to the first question on our list. And again, in terms of the panel, feel free, just to raise your hand and jump in to answer the question. And we will go to as many panelists as those who feel that they have something to add to the answer. First question. If positive for COVID within the past 90 days, is it correct that it is medically recommended and advised to wait 90 days before getting vaccinated? And so I turn to the panel. Anyone who would like to jump in on that, please proceed. First, of course, unmute yourself. Yeah. Dr. Agenbaum, please go ahead.
Yeah, I was waiting to see if any of my co-panelists would jump in ahead of me, but nobody took the bait. Originally there was some concern about waiting around previous infection, and there are some theoretical reasons why that might be the case, but they don't seem to be borne out. And currently the recommendations from the CDC are that you can receive vaccine after infection, but presuming after symptoms have abated. So you shouldn't be sick when you take the vaccine, but you can really step up and take the vaccine right away as soon as you recover from infection. And there are no untoward effects.
Okay, thank you. Would other panelists like to add to that?
I would just add, I think the 90 days might come from the recommendation that you should wait 90 days if you've received monoclonal antibodies or plasma. So you would have been hospitalized and gotten infusions for that, and you'd probably know. But I agree that the recommendation is that if you have COVID, you should actually get the vaccine as soon as you can when you're out of your isolation.
Okay. Thank you. All right, I will go to the second question we have had previously submitted. I am a 32-year-old woman, and I would like to have a family in a couple of years. I am concerned about being able to get pregnant, having a normal pregnancy, and a healthy child if I take the vaccine.
That's definitely for me. I should mention, I'm a practicing obstetrician gynecologist, so I also see patients. And this is a very common question and concern. So thank you for my colleagues at the American College of Obstetricians and Gynecologists and the Society of Maternal Fetal Medicine and the CDC that recommends pregnant persons, lactating persons, as well as those who are planning to become pregnant to get the vaccination. So studies have already looked at this a couple of times, specifically guidance from the American Society of Reproductive Medicine, that those who are planning to get pregnant, there's been no effects in their ability to get pregnant or effects on your fertility for women as well as men who have gotten the vaccination. There have been some concerns that men who have had the COVID infection have had problems with impotence as well as fertility, but those are for men who have gotten the infection, not the vaccination. Now, you were concerned about the effects on a pregnancy. So they looked at this data. There's been about over 130,000 women who've received the vaccine. These were healthcare workers that received it early on in the initial surge of the COVID pandemic, and several of those who have been in the safety registry, and compared what has happened in their pregnancies compared to those who, normal people or other people who haven't gotten vaccination in the past. So there's no real difference in any of the pregnancy outcomes. So no difference in the rates of preterm birth, no difference in the rates of stillbirth, no difference in the rates of anomalies, no difference in the rates of miscarriage, no difference in the rates of other medical complications such as diabetes during pregnancy, such as high blood pressure during pregnancy. Those numbers are actually quite similar between the regular rate of those outcomes in people and those who've gotten the vaccination. So again, it's very safe, especially if you're planning a pregnancy, to get the vaccine as soon as you can. If you're already pregnant and you're breastfeeding, we'll talk about breastfeeding a little later, we all strongly recommend to get the vaccination. I don't know if any of my other colleagues wanted to add anything, but those are very common questions and concerns that I'm asked about all the time.
Thank you, Dr. Claire. Anyone else on the panel wishing to add anything to that?
I just wonder, I'm just speaking here as a mother of 7, and I understand the worry and concern that people would have over these issues. During the years of pregnancies and breastfeeding, you're very hypersensitive about anything going on, right? You want everything safe as possible. But I wonder, Camille, if you could address, you know, we're getting the vaccine if we're pregnant or breastfeeding because we want to protect ourselves and our families. What about the risks of getting COVID during the, so we're balancing the risk of the vaccine with the risk of getting COVID while you're pregnant. So could you talk about that?
Thank you very much for that question, Dr. Zechler. So patients that are pregnant that have received the COVID infection are more likely to be extremely sick, very seriously ill. Those patients are more likely to be admitted to the intensive care unit. They're more likely to die from COVID infection. They're more likely to be on a mechanical ventilator. So for pregnant people, especially getting COVID infection has extremely higher consequences, severe consequences during your pregnancy. So for you in particular, when you're pregnant, definitely continuing, regardless of your vaccination status, to wear your mask, avoid socially distance, avoid large groups, wash your hands as we've always recommended, because the consequences of you getting the COVID infection can lead to dying or being in the intensive care unit and being on a ventilator. So thanks for elevating that because that's really, really important. And we've seen as the number of cases have gone up in different areas, those are the patients that we're seeing that are actually passing away and dying and leaving their children and their families behind because they've unfortunately passed from the COVID infection.
Thank you. And thank you, Dr. Zechler, for raising that question, really important. Anyone else wishing to add to that discussion at this point?
The only thing I'll add, and I think Dr. Claire may have already mentioned it, but just to kind of underscore it, because I do hear this concern a lot too, and it's one that I can really empathize with. And I know that these people are coming from a place of real love for their, future children, and they're wanting to do the best thing for them. We're hearing in the news now regular reports of pregnant women dying, unfortunately, from COVID. And that's a real tragedy because these could have been, at least the vast majority of them, prevented. And in terms of thinking ahead to what you can be doing to protect your future child when your pregnancy is over. So even once these vaccines are approved for infants as young as 6 months, which will be sometime in the coming months, for the first 6 months of their life, they will be vulnerable. But maternal antibodies, or the immunity from the mother, can pass to them and protect them, either if they're vaccinated before or during pregnancy or with breastfeeding. And so that's one way you can actually be sure that your child is protected in those first few months of life. And it's another reason to get vaccinated.
Dr. Anderson, thanks for mentioning that. We've seen that in many other infections in patients that we take care of, which is why we recommend people to get things like DTaP and other vaccinations for that added protection for their baby. And what we've seen is that people who've gotten vaccinated, those antibodies can protect their babies after birth, because it's been seen in after birth. So that's very important. And similarly for our people who are breastfeeding, lactating persons, and those antibodies have been found in the breast milk to add added protection for those babies. I know there was a question on breastfeeding later on, but since we're speaking along these lines, again, you can have those added protections from antibodies in the breast milk, and for those who've been vaccinated after birth for your infants, especially the first 6 months of life.
Very good, thank you. Then there are a couple of questions that kind of get into the nature of the vaccines, and so I'm going to ask the first of a couple that are kind of in that category. One is as follows. The first I'll ask is as follows. I'm skeptical because this vaccine was produced and manufactured so quickly. How do we know that these vaccines are safe? Couldn't they cause long-term problems? And it's a general question, but also specific to how they were developed. And so I open it to the entire panel.
I think, that's a legitimate concern. Most people want to have some margin of safety associated with whatever product they get, not the least of which a vaccine. But the way I sort of think of it is that we're reaping the benefits of biotechnology that's just been sprinting ahead over the very many last few years. I presume you wouldn't want to continue to get vaccines based on old platforms in the same way that you don't buy an automobile that was produced 50 or 60 years ago. So the whole idea about being able to generate mRNA vaccines is something that's been in the works for the last 10 or 15 years, and it's been used in a lot of trials, so it's not absolutely new. So although I can sympathize with the idea that it seems like this has happened very quickly, on the other hand, I think that, again, this is sort of, we are reaping the benefits of biotechnology and science moving forward. We should all be grateful for that. The ability to bring out this vaccine, this effective vaccine, this quickly in the setting of a pandemic is somewhat miraculous. And I dare say if we had to wait for old technologies to bring this stuff on board, we'd have a lot more sickness and a lot more death in the community.
Thank you.
I think I'll also add to that, that some of the patients that I'm seeing are nervous about again, how fast the vaccine was produced. And so there were no shortcuts taken in the clinical trials for these vaccines. There's two main reasons that I'm aware of that the vaccine was made quickly. So when you do clinical trials, you do them in phases, phase 1, phase 2, phase 3. And there was some overlap in the phases when they did it for these vaccines, but there was no shortcuts in any of the phases. They were doing that to try to get the vaccine to us in a faster manner. The second part is, as soon as there was evidence of safety of the vaccines, the manufacturing of the vaccines began earlier than it would have normally in other circumstances, again, in the setting of a pandemic. And so those are two really big reasons why there was faster access to a vaccine, but no shortcuts were taken in the manufacturing and the study of the vaccine.
Thank you. Anyone else wishing to add to that?
I just wanted to add that all the resources were also provided, all the funding resources were also provided for this technology and for this work to be done. So scientists who might have been working on other projects kind of stopped their work on other projects to devote their time and their resources and their expertise to this technology. So from my reading, that's another reason why this vaccine was able to be available to the public in the way that it was.
Thank you. Okay, let me move, and it is in a related area in terms of the nature of the vaccine. And actually, there's a couple of questions that were pre-submitted having to do with previous infections or having been infected with COVID-19 or the coronavirus and then having recovered. The question I'll quote from is, if you have had COVID-19 already and have the antibodies, why is the injection needed? I was told you don't need the vaccine. Natural immunity is better, and the vaccine has harmed people by getting the vaccine with the antibodies. Whoever would like to start, please jump in. Go ahead.
I don't think there's any evidence that the vaccine is harmful to people who have the antibodies. First of all, I think we should debunk that. Second of all is, natural immunity is a good thing. We're all thankful that we have functional immune systems. Those of us who do have functional immune systems, many people don't, by the way. But it's not a perfect system. And it's pretty clear, the data is pretty clear that you can improve your immunity to COVID, natural immunity, if you get vaccinated after an infection. There are a lot of unknowns about natural immunity. As people know, infections themselves can run the gamut from mild to severe. We don't know about the strength of immunity after infection. We don't know how long immunity lasts after infection. Those are a lot of unknowns to depend upon to preserve your health. It's pretty clear, on the other hand, that if you get vaccinated after you've had infection, you boost immunity, and that you're clearly protected on a log order greater than you would be just on the basis of natural immunity. So by all means, don't neglect vaccination if you've had COVID in the past.
Yes, Dr. Anderson.
Yeah, I'll add to that as well. So, to provide a comparison, so the cousins of COVID-19 or SARS-CoV-2, the common cold viruses that are coronaviruses that we all get every year, immunity from those infections is not good. So you're protected just for a short time. You can be infected again the next year, and it wanes quickly. And there's more and more data coming out that vaccination can make your immune response stronger. So more antibodies, for example, it can be broader, which means that it protects you against more variants, maybe even ones that haven't come out yet, and that it may last longer. So you may have some protection for a shortish period of time, but the goal with vaccination is to get you over the finish line in our struggle with this virus, which I hate to say it's far on the horizon right now, maybe beyond Delta.
Thank you. Anyone else wishing to speak to that? Okay, and because of where the answers were taking us, I'm going to move to a question that is actually related to what you were just saying, Dr. Anderson, and that is, how can a vaccine designed to fight against the first variant of COVID-19 work against a different variant, Delta, understanding how the human body works? That's their wording, so please, someone respond to that.
Well, I'm going to try to avoid getting too technical and into areas that are a little bit beyond my authority, so others should jump into to get into the mechanics of the immune response. But so all of these variants are related, and they're similar, right? They all are SARS-CoV-2 viruses, but the breadth of your immune response, or the degree to which it protects you against these different variants, varies. And vaccination, one of the goals of it, and what we are seeing, as I mentioned, is that it can protect you against a broader array of variants, because those antibodies, those things that recognize the virus and bind it, can either be very specific, or you can have a wide array of them. And our goal is to get antibodies, these things that bind the virus and protect you, that are very broad and can recognize a diverse array of the viruses, or all of their cousins that are to come. And so that's one of the areas, again, we're looking at natural infection versus vaccination. The advantage seems to be to the vaccines.
Thank you. Others wishing to respond to that?
Yeah, I mean, I would agree in essence. Despite the fact that the strains seem to bring subtly different things to the table in terms of potentially transmissibility, illness, and responsiveness to medications, they are all still strains of the same virus, and they have the same potential Achilles heel, let's say, in different places. And so the vaccines can work in various ways against a broad range of strains. It may not be 100% efficacious, but efficacy is preserved.
Thank you.
I just wanted to mention a thing I learned about variants along the way. And by the way, we are all learning. We're always learning about this virus. We're always learning about the pandemic, everything about it. So one thing I learned along the way about variants is that epidemiologists and immunologists, they expect variants. They watch the variants. They're thinking about the variants. They watch the ones that are going to be trouble, and they ignore the ones that aren't. So when we hear about a variant, sometimes the press or maybe our own anxieties make us feel like, oh, there's a variant, as though that wasn't expected. I mean, this is something we expect when we have infectious disease. Once I learned that, I realized it was some comfort that some experts are watching. They're watching out for the variants. They know about them. It's not like a big surprise that took everyone by storm, so that helped me to understand better how the current vaccine is covering, you know, as well as it is. So anyway, I just wanted to add that little thing. Always learn.
That actually compels me to mention another aspect of vaccination that I'm not sure people want to hear about. It's not really about all of us as individuals receiving vaccine, but the unchecked multiplication or replication of viruses in the community fosters the development of these various strains and fosters the potential development of strains that are less and less responsive to vaccines and medications. And so, in addition to being personally important and important for our families and our community to take the vaccine, it's a bigger picture important too, because all of us could stand to not have replicating virus in us, because that may foster the development of strains, additional strains that are more dangerous than Delta. So it's something to do for the community at large, locally and globally.
Thank you. And I will not wade into the scientific discussion, but we do need to be cognizant of the fact that the Delta variant emerged, all indications are, in a massive surge of cases, infections in South Asia. And even as we speak, the rate of vaccinations in one of the most populous, second most populous continents in the world, Africa, the vaccination rates are around 1 to 2%. So it is, as you just said, Doctor, it is a global issue. And in speaking about the community, our role in a global community, I wanted to take the opportunity quickly, because I want our experts to do the bulk of the talking during this panel. But there were questions concerning what the union is doing, and there was one question, and this is actually combining two into one. Will UUP stand up for the rights of their members or fold to the state? What is the union doing to support those who oppose the vaccine? I am not interested in hearing about why I should get the vaccine. My mind is made up. The union needs to show support for those members who are not getting the vaccine. UUP has a legal and moral obligation to defend our members when they are brought up on disciplinary charges. The Department of Health has issued a mandate in order in a public health emergency, which is what DOH has now declared the case to be. Under Section 16 of public health law, they can mandate vaccines, and they can require, under penalty of termination of job, that the vaccines be brought to all members of, for instance, in this case, all those health facilities that the Department of Health licenses. That's where the mandate comes from. And at the same time, UUP will fight to ensure that our contractually negotiated due process protections exist. We have been in conversations and discussions with now 2 governors going back to August to ensure that the mandate is carried out in such a fashion that the rights of our members are protected, but also, and speaking personally and for the leadership of this union, and I know the leadership of SUNY, and I hope the governor of this state, we want to make sure that whatever form the mandate takes ensures the health and safety of the communities across New York State. We have a healthcare personnel shortage at all SUNY hospitals, and indeed it's across healthcare at large. To lose more individuals as a penalty for not being vaccinated suddenly in a draconian fashion would be devastating. We have made that case, that if there is going to be a process whereby individuals are basically told they must be vaccinated, there needs to be a gradual process to bring as many individuals around to convince individuals of the necessity and the importance of being vaccinated. At the same time, as we do that, this union does have a moral obligation. A third of our members work in healthcare, but even if they didn't, our moral obligation is also to the communities in which we live. As Dr. Augenbraum was just referencing, it is imperative. And the union has been working for 8 months on a voluntary campaign to encourage people to be vaccinated. It is in our common interest to do so. And in common, I mean globally. But we will utilize all the tools at our disposal as we negotiate, as we were negotiating yesterday, as we have been negotiating this morning. That's how nonstop these conversations are going with the highest levels of the state of New York government and with our colleagues in the Public Employees Federation, PEF, CSEA, all of the statewide unions who are impacted by the mandate. So that is where things stand at present. With that, I will go to, let's see, the question on reactions. Some people have experienced severe allergic reactions. I have environmental, latex, and other allergies and have had severe allergic reactions in the past. How do I know that I won't experience a severe or potentially life-threatening reaction with this vaccine? Anyone on the panel who would like to start that conversation? Go ahead, please.
Hi, yes, okay, I can comment on this. So if you have allergic reactions or allergies to foods, to certain medications, oral medications, environmental allergies, there's no contraindication to vaccination. When people started getting this vaccination and there was presumably allergic reactions that were occurring, there was thought that patients who were having reactions or possibly allergic to polyethylene glycol or polysorbate 80 in either Moderna and Pfizer or Johnson & Johnson respectively. But to be quite frank, that hasn't necessarily played out as the allergenic substance in either of any of the vaccines. So the recommendation for people who are allergic is the same as it is for all other vaccines. If you have an allergic reaction to the vaccine itself or any of the components of the vaccine, then you should seek care with an allergist to decide how to proceed. If you do not have allergy to any of the components of the vaccine or to any of components of the vaccine or to any of the vaccines themselves, then you can be vaccinated. If you are allergic or an atopic person, it's recommended that you be monitored for 30 minutes after vaccination rather than the 15 minutes. But other than that, there's no contraindication from an allergic perspective. Of course, if you're concerned, you can ask your doctor. Some people say, I don't know if any of my medications have any of the ingredients of the COVID vaccine. And so if you have any concerns, then your doctor and allergist can help you go through that. But just because you are an allergic person, you should not be scared to get the COVID vaccine, the same way that you wouldn't be scared to get the flu shot every year with the patients that you're with the recommendations from where you're already working to get the flu shot every year. So I hope that's helpful.
Thank you. Yes. Any other panelists wishing to speak to this question? Okay. This is a question that came from an individual member, and we've generalized it a little bit, and so that we can capture concerns that we know are out there amongst a number of our members. Can you share your opinion on getting the vaccine if you received a new health diagnosis that you are just beginning to learn how to manage and is not yet managed, controlled well by medications? This individual is also concerned that a limited plan of care has been created for the new illness diagnosis and is not sure about how that could interact with the vaccine should this individual be vaccinated. So again, I'll turn to our panel for anyone who would like to respond to that.
I can start. First, I'm sorry for this member who's dealing with a new diagnosis that sounds like it's really challenging and concerning. So in the clinical trials, the initial clinical trials, and of course we've moved well beyond those, but Pfizer and Moderna had included people who have underlying conditions. You could have cancer, it just had to be stable cancer. You could have autoimmune disease, it just had to be autoimmune disease. And they didn't observe any worsening of any conditions. And now these vaccines have gone into hundreds of millions of people, and we've seen no signal of these underlying conditions worsening. In contrast, if there's a new condition that might down the road involve some treatment, maybe something that suppresses your immune system, maybe chemotherapy, maybe steroids, that's all the more reason for this person to get vaccinated now, so they're as strong as they can be going into whatever may lie ahead.
Thank you.
I'll tag team onto that a little bit. So I agree. I'm very sorry for your new diagnosis, but I'm hoping that you're asking your doctors that are treating you for this diagnosis what their opinions are, because they will have other patients just like you that will have gone through this and were potentially vaccinated, and they can use their experience to help guide you to determine what might be best for you. And what Dr. Anderson said is absolutely correct. There are many medications that are immunosuppressive. And if those are any medications that are being thought about for your treatment plan, then it may be more beneficial to be vaccinated before that, because your immune system has pretty decent memory. And so far for this vaccine, it seems like it has pretty decent memory. And so you would want to develop those immune cells that have memory prior to getting some kind of immunosuppressive medication, vaguely, without knowing what the medication would be that they would treat you with.
Thank you. Any other panelists wishing to respond? Okay, thank you. There's been, and obviously this has been something that has been all over the media, and obviously causing some concern, and there's been a number of questions that have been submitted about breakthrough cases. And this question gets right to the heart of the issue. With the current number of breakthrough cases, shouldn't we wait for an updated vaccine before instituting a mandate? There's really two questions there. One is about the nature of the mandate, which is in actuality a policy or political question facing the governor and the Department of Health, unfortunately, because as a sidelight, just so you know, the governor does have the power, and this has been part of our conversations, for the governor to intercede and to order the Department of Health to delay the mandate. Now, she has said publicly she is not in favor of any kind of delay. Privately, I'm not at liberty to, we don't negotiate in public, and so I'm not at liberty to say, but a case is being made about that. But let me go to the panel about this issue of breakthrough cases. Is the vaccine, at one extreme, those who say it clearly isn't worthwhile because there are breakthrough cases, some very serious, and then the question of maybe we should just wait till the vaccines are updated, and maybe someone would mind a comment about the issue of the boosters as well. So I'm just going to leave it open to the panel on this one because it is a big area of concern. And anyone who would like to start, Dr. Augenbraum, go ahead.
Yeah, I understand that rationale or concern, but it strikes me as playing a little bit of Russian roulette there. Concerns about breakthrough infections causing an individual to say, well, I'm just going to wait for another product that's better yet. I don't know when that product is coming down the pike, and the problem is now. The fact of the matter is that although breakthrough infections occur, and we certainly expected that they would occur with the development of the vaccine, nothing is 100%. It's all of our experiences that breakthrough infections almost to a one are mild in nature. Now, granted, there are some breakthrough infections that are severe, but those are anomalies. I can tell you in my personal experience right now, the vast majority of individuals hospitalized with COVID who are sick, really sick, are unvaccinated. And that the breakthrough infections that I've seen are overwhelmingly mild in nature, colds or mild flu-like symptoms. Again, is somebody's going to violate that rule, but in the aggregate, when you're looking at the numbers, breakthrough infections are mild. Even in that circumstance, the vaccine is doing what it was supposed to do, that is mitigating the impact of this viral infection. I would not agree with waiting for something better to come down the pike. The problem is now.
Thank you. I think I'll just
please go ahead.
From I think Stony Brook, what we're seeing here is that most of the patients admitted are admitted with Delta variant, and most of the patients admitted are unvaccinated. And so I would suspect you guys that the other institutions are seeing the same thing. And so that would mean you could deduce that the people who are vaccinated are staying out of the hospital, which is really one of the main goals of getting vaccinated, to minimize severe infection. So I would think you guys are probably seeing the same thing at your respective institutions.
I'll just build on that with respect to the discussion of boosters. So I think it may be a little bit, well, certainly the booster discussion has been confusing for everybody. But, we're not yet at a point where we know for SARS-CoV-2, for COVID-19, if this is something where we're going to continue to need to reformulate or make new vaccines like we do with flu, or like many of us think, most immunologists now think that we really do need to have an extended first series with COVID. So just like we do for polio, just like we do for hepatitis A, just like we do for these other vaccines, we need to stretch out our exposures to really get the full immune response over the course of a year, or for Hep A or polio is 4 years. So we don't see any sign yet that the vaccine is failing against Delta, where we really care, severe disease and death. And we really think that certainly the initial vaccination dose protects you well against the circulating variants, again, where we care. And that this discussion of boosters should not have people thinking that we're needing to change course to, respond to the oncoming variants. It's more to round out the immune response currently.
Thanks.
Wanted to add that because the vaccination rate in pregnant persons are so low, it's about 16%. We've also seen pregnant patients admitted with COVID now as well, and that those patients are similarly unvaccinated. And as we already mentioned, the implications of a pregnant person dying and being in the ICU are really, really severe. So I'm really concerned about those who are worried during pregnancy, and I understand what those concerns are, and happy to continue to talk those through.
Thank you. Anyone else wishing to comment on this one? Okay. We've gotten a couple of questions that have to do with religious objections, and there are a couple of questions that I will pose to the panel that are more about the nature of the vaccines and so forth. Again, but one question that is, I would say, directed at me, which is, what about the religious exemption for this particular mandate? Are members covered under Title VII of the Civil Rights Act of 1964, prohibiting discrimination based on religion? The First Amendment to the United States Constitution, I will shorten the question here by just saying, referencing the freedom of religion, free exercise clause. And does it extend to state and local governments? Yes, the Constitution is the highest law of the land. Does UUP support the membership who believe the vaccine should not be mandated, but rather voluntary? Are there any protest plans to remove the mandate? First, I'm going to work backwards. Any protest plans to remove the mandate? And as I stated earlier, there is nothing that can stop the mandate because of the nature of the way it has been issued. A protest, even a court action, could not stop it, because under New York state law, upheld in federal courts as well, is that the New York State Department of Health does have the authority, and indeed the Supreme Court ruled in 1905 that states do have the authority to mandate vaccines. And in fact, in the 1905 decision, the Supreme Court ruled that, in fact, religious exemptions were not justifications for avoiding a state mandate. The reason for it, the court ruled that the justified concern about the well-being of the community does trump an individual's rights under the First Amendment. Not to get too far into constitutional law, it happens to be part of my background, but none of our individual liberties are absolute. They are all limited in some fashion. And because of that, we do hit this situation with regard to Title VII of the Civil Rights Act of 1964. Yes, that protection exists. However, in the reading of the law, and also the way that government agencies and the courts have ruled on this, is that yes, an individual religious practices, as indicated through their beliefs consistently, do allow them and a certain level of protection against an employer. However, that kind of protection cannot create undue hardship. That's the specific legal language, undue hardship. And so in the present circumstance, if there is a physician who refuses to be vaccinated and is seeing patients and is operating on patients, the state of New York could claim that this individual, okay, allowing to go unvaccinated creates an undue hardship for the state in conducting the work that it's doing, namely treating patients. Now, such an issue could be fought. I'm using that example specifically. We could make the case, well, if that surgeon is covered head to toe in PPE, that works as a protection of the patient. It's an argument that could be made. Having said that, the courts have consistently ruled, throughout this, the past century, that the burden of proof falls on the individual making the claim. We do and have argued that there needs to be a process whereby there is a religious exemption to this mandate. We have not, the Department of Health in its order of August indicated there would not be a religious objection allowed. We're having conversations, as I said earlier, all the way to the governor. And those conversations include the need, in our perspective, and all the unions, that there needs to be some form of religious exemption. But know this, ultimately, the determination as to whether or not the religious exemption claim is legitimate rests with the employer. Were we to utilize adjudication, going to court on this, that would not protect someone from losing their job. What it would involve is going to court and fighting over years to then either get the individual reinstated or reimbursed for lost salary, wages, et cetera, et cetera. So it's a very complex case. It is not, a simple stamp. I have religious objections and therefore I'm exempt. That's not how it works. It is, as things always seem to be in the law, it's much more complex, it's much more convoluted, it's much more challenging to make that sort of case. Hopefully that's helped clarify things. It is a very complex set of circumstances. And this turns to a couple of the questions we've had about, from the perspective of religious objections. One is, I am ethically opposed to the vaccine because of the ingredients. They are filled with pork byproducts. I would need one member of the panel or several to respond to that, please.
Not true. Not true. I'm unaware that pork products are in any of the vaccines. So wherever this person is getting their information from, they should check the source.
Okay, thank you. Anyone else wishing to comment on that?
I'm also unaware. When I've looked at all the ingredients, when people come to me for possible allergic reactions, I've looked up all the ingredients. I don't think I've seen pork mentioned at all.
Thank you.
And the vaccine manufacturers have confirmed that as well.
Okay. Thank you. In a related question, and this is getting us into a little bit of a philosophical area. It is against my faith in God to take this vaccine. If the vaccine is available, then people can take it if they want to. I'm not posing a threat to anyone by not taking it. So why do I need to get a vaccine? And this, especially the last couple parts of that, the last two sentences or clauses. I'm not posing a threat to anyone by not getting vaccinated. Why do I need to get a vaccine? This gets into some territory we've covered earlier, but I think it's worth responding to because it is a common theme that we have seen in questions, but also in emails that I've been receiving from members. So anyone who would like to answer, Dr. Anderson, please go ahead.
Yeah, I'm really glad for that question. There was a couple in that flavor, which I'm really glad to get because I think it's important to discuss. So you individually choosing to not get the vaccine doesn't just impact you, it affects people around you as well. And we've talked about a few of the reasons. So one is that you being able to get infected could help fuel the emergence of variants, which is more of a population level concern. But there's two other more immediate concerns about how you being infected could impact others. So you being infected, you could infect someone else and they could die from COVID. So it's not a decision that just affects you, it actually affects your community and people could suffer from your decision. The other way that it impacts our community is that there are already cases reported, I'm aware of at least two in the United States, where there were individuals who didn't have COVID, needed a hospital bed, but the hospital was filled up with people who had COVID, most of them unvaccinated, and these people died. There was a case of a gentleman who had a heart attack and needed an ICU bed and it was not available. He died. There was a case of a gentleman who needed advanced care for a gallbladder infection. They could not find him a spot. He died. So the decisions that people make with respect to COVID don't just impact them. We can think about it like driving a car. You could choose to say not wear your seatbelt, thinking that it just affects your body. And maybe that's defensible. But you can't drive your car drunk because that poses a risk to other people, and that's not one of your rights. So there's clear examples now of how individuals' choices to not be vaccinated can cause disease and death to other people, and that's just not an acceptable risk.
Thank you. Others wishing to speak to this?
Yeah, I mean, obviously all the people on the call are not necessarily working in the hospitals that we work in, but I think one of the big considerations from the get-go about mandates was really about healthcare workers, a topic that I'm intimately familiar with. We have an obligation to the public that we take care of in our institutions to make sure that it's a safe environment. And frankly, I'm not sure I want to work with people who can't understand that they're potentially getting ill raises all sorts of potential threats to the safety of our patients. And that ought to be patently clear to people. So yes, in fact, you not getting vaccinated can have direct implications for other people. That seems to be a fallacy this person is operating under.
I'd like to just comment for a minute on the workers in the long-term care facilities. I mean, if we had had a mandate sooner for workers in long-term care facilities, we would not have lost so many elders in our community, that we turned a blind eye to that problem of so many grandmothers and grandfathers who did not deserve to die yet, in just in the thousands. And it's just, the idea that today in Onondaga County, I did a short survey of assisted living facilities. 70% of the staff are vaccinated and only 30% are not, going into this mandate. So that means that people can bring in the COVID virus to the elders and the other frail people in those facilities, and it can spread so easily inside there. And the same can be said for jails and prisons. So I think, and college campuses, different environments, right? But thinking just about long-term care facilities and what a travesty it was that we weren't able to get better control through vaccination is unfortunate. And again, it goes to our responsibility to protect other people and not just ourselves.
Thank you. Anyone else on that? I'm going to, and we hadn't intended this way, but I do want to respond to the question that William Mihailovich has posed, because it is related to what I was talking about in terms of the legal situation and the court situation, where a federal district court upstate has issued a temporary restraining order on the Department of Health's mandate that vaccinations occur and be mandated for all general health. I'm just using the term general health professionals. And that was because of a lawsuit brought by the Thomas More Center, I believe it is. But what it was based upon is a challenge based on religious objections, because, and this was a question that was posed regarding the makeup of the vaccine, that some of the use of fetal tissue in the design or development or manufacture of the vaccine. And I don't know the technical aspects. I do know the legal side of it, which is the temporary restraining order that was issued by the judge last week has been extended to, yes, as William points out, until October 12th, where he has said he will issue his decision. That has brought about the situation that, yes, at Stony Brook, and indeed I know at upstate, I'm not positive about downstate yet, but the institutions are accepting what, for lack of a better term, are applications for a religious exemption to the vaccination, because There's an uncertainty on the part of management, and for that matter, in UUP, we're not sure which way the judge is going to go on this, having to do with the religious objection. And so what SUNY is doing is, out of an abundance of caution, uncertain about what the judge may rule, they're accepting applications. If the judge should rule that there is no legal basis to the claim, then SUNY will proceed, I am sure, based on what DOH has said so far, and that is that there will be no religious objection. That's part of the DOH order. I'm sure that the Moore Center will appeal. This will certainly work its way through the courts all the way to the United States Supreme Court. But having said that, about the makeup of the vaccines, could any of the panelists, and there was a question, I don't have that screen open to ask it verbatim. There was a question asked about the development of the vaccine and its relationship with the use of fetal tissue, and thus leading to some ethical objections to the vaccines. Would anybody like to comment on that, please?
I can speak to the use of aborted fetal cell lines. Some of the original fetal cell lines were created probably in the 70s and 80s. So those were cell lines for which many different things are used, but there's no, in my reading and learning, there's no current fetal aborted cell tissue in the vaccination, but the creation of those cell lines were from old cell lines back from the 70s and 80s. So if my colleagues wanted to chime in, I'd appreciate that too.
This was a new question for me, and a new thing to research. So I'm glad for the question, the opportunity to look into that. So I learned the same thing, that fetal cell lines have been used rather widely in vaccine development for various vaccines, and these would have been elective abortions going back to the 70s and 80s. But Pfizer and Moderna did not require the use of any of these cell lines in developing their vaccines. Johnson & Johnson did require the use of one fetal cell line, but again, this would be not aborting fetuses to create the Johnson & Johnson vaccine, using cell lines that were created decades ago and are now used widely as just self-replicating cell lines. But Pfizer and Moderna, the mRNA vaccines, have nothing to do with the fetal cell lines at all.
Thank you. Anyone else wishing to speak to that question? Okay, a question that we received this morning, actually a couple of these came in earlier today. Please explain the purpose of the VAERS system, that's VAERS, and why it is misleading to look at the raw data. Anyone who would like to jump on that question, please go ahead. And perhaps it might be helpful for someone to define what the VAERS data is first, so everyone's aware of what we're talking about.
Well, the VAERS is a vaccine reporting system, a national reporting system for adverse effects from vaccines. It's been in use for decades, and it's largely based on reporting from the field. People report adverse events, and that's how the CDC and the FDA gather data, post-marketing of vaccine adverse effects. It's not a study. It can't substitute for data from well-controlled studies, but it's a very good and very effective process for picking up small signals and obviously larger signals that there may be problems with vaccines. And we depend on it very heavily. We depend on clinicians to report from around the country when there are adverse events seen. And by and large, physicians are very good about this.
Okay, thank you.
I guess maybe I'll pose a question instead, because I just don't know the answer to this, but it might be helpful for some of our listeners. Does it have to be a clinician that reports to VAERS, or can patients report to VAERS? Yeah, so I think you're saying, sorry, I think you're muted, but patients can report to VAERS is my impression as well. And so I think then no matter who reports to VAERS, there will be some kind of investigation about what happened. But I do think that's important to note, that anyone can present information to VAERS. And something that we say in our world, if I'm saying this correctly, is that there might not be causation, right? Is that the right way to phrase it, you guys? That we may feel, or it may appear that there's a link between some kind of adverse event and the vaccine, but it doesn't necessarily mean that the vaccine caused the adverse event. And that's why it's important. Yes, thank you, Dr. Anderson. She's saying it in the chat. So I think that's also important to note here, and why it's so important to do these well-run clinical trials to try to help to determine if there's causation there, rather than correlation.
I do want to mention that a lot of concerns were initially brought up regarding menstrual irregularities in the vaccination, and the NIH just recently provided funding to look at that, so that information will be forthcoming through well-designed studies to look at menstrual irregularities and those who received the vaccination, since that concern has been brought up by patients over these last several months. So look forward to hearing more about that.
Thank you. There was one question that came in, I think it was either late yesterday or early this morning, and that is amongst all of you, and I kind of expect a certain answer, but nonetheless, I'll pose the question. Do you individually have a preference amongst the vaccines that are available at this stage that you would recommend over the others?
So I've been telling patients to take whatever you can get in terms of vaccination. I will say, there are some patients, if there's a history of blood clots or a young woman who's on birth control pills, who maybe you just want to talk to about the data for Johnson & Johnson, because that is out there in terms of the possibility of adverse effects. I am not saying that you should not get Johnson & Johnson, but if there's any concern and you have any of that in your history, just make sure you don't just completely write off the vaccine and talk to your medical doctors about it.
I just have to jump in regarding that. So that rear risk of blood clots was actually extremely rare, extremely small numbers of cases, probably even lower than for those who are on birth control pills, etc. So there was that short period of pause for the J&J vaccine, but those case numbers were extremely low. And so we haven't been telling people not to get it, but as usual, to continue to monitor with your doctor. I don't know if Dr. Ogden-Brown or colleagues have anything else to mention.
No, I just think it's kind of interesting, actually, that after an initial period of a flurry of activity about reporting about thromboses about 6 months ago, I really haven't heard much else since. So I don't know what happened with that. And I think it also pays for everybody to sort of reflect on the fact that, there's no such thing really as a free lunch, and that we all readily accept that there are the potential for side effects with almost any intervention that we incur. If I give you an antihypertensive or an anti-lipid medication, there are always potentials for side effects. But it's for each of us to weigh risks and benefits. And I think the message that comes out of the experience with the vaccine is that the risk of the vaccines, although they may be there, are very, very, very low. And in our daily activities, we take much higher risks doing all sorts of things. I'm sure if you reflected upon that, you would realize that that was true. The benefit, on the other hand, of getting the vaccine for yourself, for your family, and for the community at large is clear. And so I think that's an issue that everybody has to reflect on.
Okay, thank you very much. And I understand that we have a couple of panelists who are up against the clock, and I appreciate those who will have to jump off for taking the time and being a part of this. I really appreciate your dedication to our communities in sharing your expertise. obviously not just on this panel, but also in the work that you do day in and day out for all of us. So thank you. I think Dr. Claire and Dr. Neveda Mudrov has to, both of you have to jump off at a certain point over the next few minutes. So for the audience, if they vanish, it's not because of a question that popped up, it's because of a previously established obligation that they have. We've reached the end of the pre-submitted questions. What we're going to do is we'll open things up for folks to raise their hands. But first, I'd like to ask Dr. Zechler if there are any questions within the chat that you would like to bring to the panel. There is one that I'm going to respond to because, again, it's directly related to what UUP is doing in negotiations from Kylie Deese. Has UUP presented an agreed upon option for SUNY employees to have weekly testing? We have heard that the new governor declined this. PEF is getting a mediator. Is UUP? There's a few things there. One, UUP and SUNY negotiated what's called a memorandum of understanding. That was negotiated last fall, which established a mandate for all those in our bargaining unit, everyone we negotiate for, okay, roughly 37,000 people across SUNY, that we would be tested, surveillance testing, just like students were being tested, we were going to be tested. All the unions agreed to that. But I will tell you, in a spirit of openness, I led the way on that. I and the chancellor and I wanted to ensure that our communities were safe. And I felt that at that point, that combined with mask wearing to the greatest extent possible, remote education, providing PPE for our members in the hospitals, all of those things were the safest and necessary steps to be taken. That negotiated agreement was updated in June. And under that agreement, what we included was a provision that those who voluntarily indicated that they had and informed management that they had been vaccinated, they would only be tested once a month as part of surveillance testing at a maximum. Those who did not voluntarily indicate vaccination status would be tested weekly. Now, I don't know if you paid attention to it at the time, but it was kind of humorous for us here in UUP and in conversations that I've had with the chancellor that the state of New York, the city of New York, the state of California, all across the country, you started hearing about test, vaccinate or test, vaccinate or test. We didn't make a big deal out of it, but I kind of like to refer to it as the UUP SUNY model because we were the first to put that in place long ago. But having said that, that's a memorandum of understanding between us and SUNY. The Department of Health vaccination mandate supersedes it. It is statute, it is state law, and so therefore they can mandate it. Why has PEF gone to a mediator over what they claim is an impasse? It's because they can. You see, they're negotiating with the Governor's Office of Employee Relations across several agencies. They have nurses that don't just work in SUNY hospitals, but in other facilities. And for that matter, they have other individuals who are subject to this vaccination in various agencies. We just have to negotiate with SUNY. And so therefore, they are claiming that the Governor's Office of Employee Relations are not negotiating in good faith. And so they want to go to a mediator. What I will tell you is that the president of PEF and I, Wayne Spence, we talk several times a day, strategizing so that we all get it to the same place. There will be a common agreement for all of us to ensure some level of due process. It is not a case where they've gone on ahead and have a more powerful weapon. They're just in a different circumstance because they have various agencies they have to negotiate with. And in order to do so, they work through the Governor's Office of Employee Relations. We have not done so. We're working directly with the Governor's Office. It sounds complicated, and believe me, at times it is immensely complicated because you're dealing with different individuals, personalities, and political powers. But that's the long explanation for that, okay? With that, I will turn to Dr. Zechler if there are any questions that you think would be great that showed up in the chat that you'd like to bring to members of the panel.
Sure. I just want to comment a bit about that, what we were just talking about, and then I'll move to a couple of questions there. We were just talking about this decision between whether you want to get the Moderna or J&J or Pfizer or whatever vaccines. It's what I think sometimes that indecision or concern causes delays. And I just want to emphasize that what is known is that delay can be the time between now and your imagined vaccine can be the time you contract COVID. So it's like those of us who have been watching this and who have family, friends, patients at the clinic here that I work for, you know, they wish they didn't wait around thinking about all this and considering it. They really do wish that they didn't wait like that. It causes an unnecessary delay to be kind of trying to decide between all that. What we know is that these vaccines are safe and effective, and that waiting could cost you. So I think that the delay part and the indecision or this complacency, like this idea that it doesn't feel urgent, for those of us who've been closer to COVID, we feel it's urgent. It's urgent that we get ourselves and our families protected. So these kind of indecision, don't let that be the thing that causes you to delay. I could tell you stories. I'm not sure we have time for that, but literal stories of people who waited, hemmed and hawed, and then they brought COVID to their aging parents. Their aging parents were in the hospital. It was a real big ordeal, right? And if they had just not waited, that might have been, and probably very likely would have been prevented. So that delay is something I wanted to bring up. But I wanted to, from the chat, I think we have someone who's asking about what's going on in our specific institutions as far as beds and availability and that kind of thing. And I think that that's important to think about, because I think most of us look at a county level or community level. We don't think about each institution as much as that. But does anyone want to comment? I can tell you hearsay from nurses that call our clinic and talk about conditions on the ground. It's upsetting because they'll be feeling, about a week ago, a nurse was expressing to us that, you know, I just feel like I'm 2 days away from, we're not going to have beds, you know, like it just felt really uncomfortable to her. And that kind of goes up and down in our community, depending on what services you're talking about. And I recently also talked with just a primary care provider who said, I did not think I was going to be practicing medicine in what I thought of as like the third world, because I can't access my patients the various kinds of services because I can't get them because people are leaving healthcare for the lack of protection and for concerns about contracting COVID, or they've got COVID, or they're out because they were exposed to someone who had COVID. And so there's just so much short staffing and so much need, months and months to get people the tests and treatments that they need. And so that is a frustration that I think people are feeling far and wide as a long-term situation we've got going on the ground. So asking the questions and staying informed about how many cases, how many people are actually dying, is a good thing to do. And as we can see, the whole country, if you look at I put a link to the map, one of my favorite maps, you can see the whole country is suffering much worse than we are right now, but that can change. And also we've already seen New York City and places closer to us, decimated by this. So it's good to actually get those numbers, and you can get right to some county level and even township level numbers online. Anyone who wants to go through that kind of thing, I'm always happy to take calls and show you how to find your way around some data. Any other comments about what's going on in hospitals right now in terms of ICU beds or things like that? If you want to say anything more about that.
I work at University Hospital of Brooklyn and also at Kings County Hospital, which is right across the street. And the census between the two hospitals on inpatient for COVID cases right now is hovers between 40 and 50, which is nothing like what it was in the winter, spring of 2020, nor in the early winter into early spring of just last year. So it's a third, but case rates definitely went up through the summer. And I think there's a great deal of concern about what we're can expect to see as the weeks proceed and kids go back to school and the winter months or the colder weather begins to close in and people start spending less time outside and indoor. So we don't really know. I think at the moment, some of us are rather pessimistic given our previous experience. So we're a little bit fearful, but the numbers are not nearly as bad. But we do have open COVID wards. So
Thank you.
Thanks for sharing that.
Any others wishing
So-
to? Yeah, go ahead.
Yeah.
And if I would, I would
Anyone else
just
want to
add,
comment on conditions?
yeah, anybody else with the conditions? Yeah,
I'll
Go
just
ahead.
comment. Oh, sorry, Brianne, were you gonna go ahead, Dr.
No,
Nevada?
it's okay. Just from Stony Brook's perspective, I'm not on the inpatient side very much, but they send out information or they have it available on the Pulse on our website regularly. And I think it's been between 60 and 70 patients admitted. I can check actually while we're talking more, but the last time I've checked, it's been about that.
So someone is asking about that mRNA. Does it get in your DNA? I just put up a couple of links that I have because I answer this question a lot, but I think you all would be much better at answering what happens with it. Is it messing with our DNA or not? How does that work? What's going on with the RNA? How do we know? How do we know it's not, you know?
it does. I mean, what we know about it, it really has nothing to do. It bypasses the DNA. And again, I don't know when people pose these questions, how much they know about, cellular mechanics and how these things operate. But mRNA vaccines entirely bypass DNA and don't get involved in that at all. They make the cell, through other mechanisms, produce proteins that mimic the virus, and so that the body creates an immune response to that. But it is a temporary thing that lasts a very short period of time, just enough to prime the immune system to recognize these proteins, and then it's gone, and it never gets involved in DNA, intercalating into the DNA.
Thank you.
good,
I
thanks.
think we've determined that fetal tissue isn't used in that as well. Camille answered that before she stepped off. The next question is, what is the case threshold for activating hospital surge levels, and are we there now? This is from Ellen McTeague, a nurse practitioner.
So I'm going to make a general comment, not speaking specifically about my hospital, but so the situation in the hospital is a different kind of problematic right now compared to where we were. I agree. And last winter was a truly scary time when cases were going up, and we were full here at Upstate as well. We had cases in the hundreds. Now we're somewhere between 40 to 50, but our caseload is coming at a time when across our region we also are having severe staffing shortages. And so the real challenge is, sure, we only have 40 to 50 cases, but we're also trying to catch up on elective surgeries that we had to postpone. We don't want to tell someone they have cancer and we can't operate on them for a year because we have to shut down because of COVID. And now we're trying to balance potential surges in COVID with making sure we have adequate staffing, even just for the day-to-day things. And so it's really, again, across the region, we're really at a challenging point, and there's two competing forces of COVID and growing cases and the Delta variant, and then the staffing issues.
If I might just interject what Dr. Anderson has just highlighted, and actually several panelists have talked about this. Please, everyone who's in the audience, please understand when we are in conversations with the governor's staff, SUNY they are convinced, they have seen it. The chancellor's been out to the hospitals, has seen the effects of short staffing and is very concerned about it. Where we are in terms of negotiating with the governor and her staff, the emphasis we make is we are not opposed to vaccines, absolutely not. And as I have said earlier, the mandate makes sense in terms of policy, in terms of healthcare policy, given the global pandemic. At the same time, what the Department of Health is doing with a mandate and a draconian punishment for those who are not vaccinated will create a healthcare crisis worse than existed in those early months of COVID. that not only will be in a circumstance where we're dealing with COVID patients, we're going to be dealing with patients through the normal span of a healthcare facility as the numbers of personnel diminish still further. Over 10 years of state funding cuts to the SUNY hospitals has undermined the staffing numbers. And now with people getting exhausted, burned out, and if they start, terminating people across the board, remember that CSEA represented individuals. It's PEF nurses, it's our members. It will have a dramatic and destructive effect. That is our position. We believe if there's a mandate, and the DOH has that power, it's got to be done right, humanely, and in such a fashion that it does not endanger the health of the communities. That's a point that we are insisting on. And hopefully the governor is hearing it. She's hearing it from all of the different unions. It's the same message. And it is a case where it must be heard, because we're going to be in a real serious crisis, worse, as I said, than we faced in those early months of COVID, as bad as that was.
Thank you, Fred. I want to bring up something that someone is saying in the chat here. If a UUP member is injured by the vaccine, will they be compensated by SUNY or New York State, as they are the ones mandating it, or will they be on their own? I can comment when you're done about it.
Yeah, and we did get this question in, and thank you for it. It's an important one. No, there will be no compensation in such circumstances. UUP does not provide that. It would be provided by the state of New York, but no, there would not be grounds for a disability claim based on a response that was extreme to a vaccination. And go ahead, Dr. Zechler.
So you're saying you don't think a New York State workers' compensation case can be initiated in this case?
That's correct. Yes.
It will not be.
It will not be.
Right. So I would just like to comment a little bit about that. We here in the Occupational Health Clinical Center are part of a statewide network of clinics across the state. And while I believe you about that one, that may very well be true if it's a reaction. We do handle workers if it's to do with your job and you got, contracted COVID, or, you need time off to go get the vaccine, or there's some kind of advocacy that is needed. The clinics really are ready to go to bat for workers. We are pro-worker. We are on the side of unions. We really want what workers need. And if you need to talk about the vaccine with a doctor, we can offer those services. If you need to, any of these things. But one thing I want to mention is, if you feel you've had COVID that's work-related, caught on the job, we have now starting to really see how the New York State Workers' Compensation Board is going to be handling those things. And we've been seeing, it takes people a while to find us sometimes, to realize this is work-related, or it might be, and then when they get the assessment, when they come through, we're starting to see some long haulers who they can attribute the catching of COVID. It was transmitted through their work, and then they develop long haul symptoms. It just, I can tell you, very sad situation, very unknown, scary situation, because a lot of wild symptoms, unusual situations, people who are young in the prime of life, the cases that we're seeing. And so, but we are able to work those through the New York State Workers' Comp Board, and we're working closely with the New York State Workers' Comp Board to make sure that these kind of cases don't get hung up. We can never make any promises. The Comp Board is good at hanging up cases and making people's lives difficult who are just trying to get health care, but they are willing and listening to us regarding these work-related cases. So I just wanted to bring that out in case your members and any of us need to know that. Is a thing, work-relatedness can be established with regard to COVID. They are accepting them. They're processing them.
And thank you for clarifying that. That's really important, Jeanette.
Yeah, it's super important. I don't know about just the adverse reaction to the vaccine, because a case could be made. You're not just getting it for your work, you're getting it for your life, so
exactly.
It's not only work related, but yeah, we've seen plenty of workers die from COVID, plenty of workers, which we commemorate every year. And we've seen plenty of workers sick with COVID. So it's and I work with low wage workers who suddenly became essential workers. Before this, people didn't notice them so much. But now we, really concerned about those kind of transmission in the community is often in the workplace for people. So here's some more questions. If we are terminated for not taking the vaccine, will we be able to get unemployment? Christy Sage wants to know.
Yeah,
Fred, maybe no.
yeah, it depends on the circumstance. And that's why we're involved in the negotiations that we are. If someone is terminated for disciplinary reasons, which technically that's what this could be, if it doesn't turn out to be negotiated in a fashion that we want it to be negotiated, then that individual would not be eligible for unemployment. And similarly, if an individual says, I don't want to be vaccinated, so I'm resigning my position, again, you would not be eligible. So it is a case, and we know that the private hospitals who have been really rigid, and you look across the country where they put mandates in, especially in non-unionized settings, where the mandates are simply, you've got 2 weeks to get the vaccine done, otherwise you're terminated immediately, no rights, no protections whatsoever, which is terrible and inhumane, but similar kind of circumstance. So what we're trying to get is a process that will allow for counseling, for workshops, for individual one-on-one sessions to try to get individuals to understand the importance of being vaccinated without a loss of their jobs, their professions, and because they're needed to provide healthcare in these circumstances.
Thank you. I don't see anything else. Oh, here comes one right now. Is it wise to have people with underlying medical conditions? Wait a minute, now it moved on me. Sorry. Is it wise to have people with underlying medical conditions to be working in a hospital setting with all types of people, vaccinated or unvaccinated? Clarence is asking. Maybe one of the docs can answer that.
I'm not sure I understand the question. Is it wise to have people with underlying medical conditions working in a hospital, I guess, because it sort of says with vaccinated or unvaccinated people. I mean, we do what we can in terms of employee health, and assessing people's risk and assessing whether their specific work environment is safe or unsafe. We have all sorts of measures in place to protect people from getting transmissible agents. We have isolation procedures. So I think hospitals do a pretty good job at assessing risk of their employees and, in general, protecting them against acquiring infections or medical conditions in the hospital. And the same thing I think is true with COVID. I mean, we try to, as best as possible, identify people coming into the institution. We have policies in place for people to use PPE properly. So I think everything that can be done is being done. Again, like a lot of things, it's not a system that's foolproof. And it's possible that people get exposed to things, and we have to be aware of that, and we monitor for that and audit that. I don't think it's unsafe for people with medical conditions to work in hospitals.
The only thing I'll add to that is I appreciate the question from Clarence, and I would say it depends, right? So I was working on the COVID teams, and there were times when I felt safer working on the COVID teams in January with my PPE and full protection than I did out in the community with high case numbers. And with underlying conditions, wherever you are with COPD and asthma, unfortunately, you'd be at risk of a worse outcome with COVID. And so the recommendation would be that you get the vaccine regardless of whether you're working from home or working in the hospital.
Yeah, great. Well, first and foremost, I want to thank the members of the panel for taking the time and providing so much information for all of us who have joined this event. And as a reminder to all who are on, we're going to do another one on Friday at noon. And the intention, again, is to provide as much information as possible. There are a couple of questions, and I noticed, William, your question as an example. We are holding on to all the questions, those that, we got some others also previously directly to our portal that got into very specifics about individual cases. We will ask panelists who would like to respond to those to do so if they can. And then there's also individual questions about employment status and protections, and we will connect you with individuals at your chapter, that's the union organization, at your campus to provide you with the answers you need. And just as a reminder, for those who are not vaccinated, if you are called in for a disciplinary hearing, if you are a member of UUP, you will have UUP representation. If you have not signed your card, if you are not a member of UUP, the reality is the state of New York does not require unions to represent those who are facing disciplinary matters to be represented by the union. And we do not. So if you would like to change that status, you can go to uupinfo.org. You can join, you will have representation, but know this, whether you're a member or not, my commitment, our commitment is to negotiate on behalf of everyone we represent, the most protections we can. But at the same time, our goal is a healthy, safe community for all of us to live and work in. So thanks to all of you who joined us today. Be safe, be well. Please get vaccinated and stay in touch. And I look forward to working with you as we go forward. Thanks, everybody.